Welcome to another episode of IRILLIC Spotlight. Today, we are honored to have with us Dr. Abhishek Sharma, Senior Consultant in Breast Onco-Surgery at TATA Medical Center, Kolkata.
Thank you, Dimple. Thank you so much.
In your experience, what are the biggest limitations of traditional blue dye and gamma ray probe techniques you have faced during SLND?
Well, I have trained in both the methods using the ICG as well as Sentinel and as well as the blue dye and the gamma probe. So when we started doing Sentinel lymph biopsy back in AIMS, we used to use only gamma probe and the blue dye. The major problem with the gamma probe is availability. Because see, it's got a radionuclide dye, it has to be injected in a different department. Then the patient has to be shifted to a different department. There is scheduling issues. There are issues of coordination. A major problem with methylene blue is identification. So I've seen the entire spectrum, from methylene blue to gamma probe, and even use fluorescein, and then I have come to use the ICG.
How does ICG technology improve precision during breast cancer surgery? I mean, what is your experience in this?
The major advantage with ICG is that it is entirely under the surgeon's control. We inject the dye just when the patient has been intubated, and the entire process remains within one department. So there is no problem. Sometimes with gamma probe, we have faced problems. Patient has been injected with the dye, but then some scheduling issues have happened, or the patient had a spike in blood pressure. So, it creates a real problem. Secondly, the precision also increases because we can see real-time flow of the dye. So we can actually see the dye going from the point of injection, taking the route of the lymphatics. You can actually see the lymphatics and you can see it going all the way to the node. So you can basically trace, it's like a treasure hunt. You can actually trace down the entire pathway of the lymphatic. You were very, very confident that this is the lymphatic that is draining from the breast onto the lymph nodes.
Sir, have you seen ICG technology reducing unnecessary tissue dissections or surgical morbidity in breast cancer patients? I mean, does it happen in your own practice?
Yes, quite a lot actually. See, there are two aspects to this. One is the sentinel lymph node biopsy, and the other is the flap surgery. So when you're doing sentinel lymph node biopsy, basically because you can see the entire tract of the lymphatics going, so your dissection is very targeted. You are not dissecting unnecessary lymphatics. One of the major advantages of sentinel lymph node biopsy is sparing lymphatics, which are not involved. So you can dissect only what is required. In terms of flap surgery, when you are doing a flap surgery and seeing ICT to see the perfusion status, you have a very good idea of how good the perfusion is. So that avoids unnecessary dissection all around the flap. So in both the cases, ICT is really helpful in avoiding unnecessary dissection.
From a perspective of a new user, are there any initial learning curve or skepticism while adopting ICG guided procedures?
So see, I switched on to ICG in 2018-19. Before that, I was using Gamma Probe and methylene blue. So in the initial, yes, there was a lot of skepticism because it was a new technology. We were not very sure. But as I used, I think it was around 20 or 30 cases that we got, really comfortable. The technology is very nice. It's very user friendly, and the best part is, so we don't have to, call up another department or get patients shifted from here and there. So it's very easy to use. It's very user friendly. But in the beginning, the problem that happened is the timing of your incisions and tracing the lymphatics. So those who are new, we have a lot of fellows who are trainees. So what I tell them is initially when you are using ICG, be very very patient because it's very it's very easy to cut the channels. That happens when you are early in the learning curve, and then the dye spills over, so everything becomes messy, and you can't really pick up the lymph node. So refrain from being very quick in your surgery. Refrain from being very fast in early dissection. Once you have a hang of it, then you can go really fast. But cutting the channels is something that happens when you are early in the learning.
Was IRILLIC helpful during your journey? I mean, because you came from UK to India.
Yeah, I think it was a pleasant surprise when I came back and I started working with IRILLIC. There were two things. One, the technology was very user friendly, and second, it was an Indian company. So there was an emotion also attached with it that an Indian company has designed such a good product, and so we very quickly adopted, and this is one of the centers which was very early on associated with IRILLIC, and we have published a lot of papers based on the use of ICG. And so I think IRILLIC has been a very good part of our journey here at Tata Medical Center in Pune.
Thank you so much, sir, for your time.